Good morning or afternoon, depending on where you are joining us from. Thank you all for being here. Welcome to the launch of Lifeline's groundbreaking report. The problem with 988: how America's largest hotline violates consent, compromises safety, and fails the people. My name is Myles Markham. I use he, him, or they pronouns, and I am the Director of Development at Lifeline. I am a native Hawaiian and Japanese American person. I have curly, short brown hair, facial hair, and light brown skin. Today, I am wearing a gray sweatshirt and a thin gold chain necklace. As many of you know, Trans Lifeline is the largest direct service nonprofit in North America. We exist to connect our community to the resources and support we all need to survive and to thrive. Since the spring of 2022, Trans Lifeline has been leading the Safe Hotlines campaign to advocate for crisis hotlines that are safe, consensual, transparent, and relevant to the individuals seeking help in their most vulnerable moments. The report we are here today for comes from the value of centering the lived experiences of those who use crisis hotlines. In today's presentation, you'll get an overview of 988's various policies and practices, our concerns around safety, transparency, and consent, and you'll hear our recommendations from help seekers to improve 988 services. Our hope is that 988 and other hotlines adopt these recommendations to create safe, consensual crisis care for all help seekers. Our program today will begin by hearing from alvar Horton, Trans Lifeline's Executive Director, and then you'll hear from our advocacy department leaders on their top findings from the report. Throughout the presentation, if you have questions, please submit them by writing them as a YouTube comment. And if for some reason we don't have the opportunity to reply to your specific questions, you'll be able to send us an email after at advocacy@translifeline.com. Now, without further ado, I am delighted to introduce you to alvar. The new executive director here at Trans Lifeline, comes to us with a wealth of experience in nonprofit leadership. They have been a leader in trans advocacy and racial equity work for many years and bring to their role with us a passion for building a world where queer and trans folks of color are resourced, celebrated, and honored. Hi, I will let you take it from here.
Hi, everyone. It's such an honor to be with you all today. My name is Alvar Horton, and my pronouns are he, they, or ella. I have the privilege and the gift of being the new executive director here at Trans Lifeline. For folks who may have visual access needs, I'm a human with short, buzzed, dark hair with light brown skin. I'm wearing glasses, I have tattoos and piercings, and today I'm in a black button down shirt with some cream colored print. So if you hear this voice, that's who's speaking. For my folks in the space that may have auditory access needs, my intention is to speak clearly and slowly. I'm so proud and humbled every single day to be a part of Trans Lifeline. Our work is rooted in this belief that all trans people deserve the resource and love it takes to choose our aliveness, to experience the sense of freedom in our bodies, and to lean into community care when the world feels small. Right now, there are daily reminders that trans people are actively being policed, disappeared, and our bodies are being legislated away. With over 600 active anti-trans legislation in 2024 alone, this report matters now more than ever before. Our people deserve safety and autonomy, and to be able to process the challenges of this world without fear of experiencing more harm when they reach out for help. Trans Lifeline exists because we want to believe in a world where trans people get to live, where we can be more than our memorials, and where we can grow old in peace and with our inherent right to safety. This report feels like a promise of our commitment to our community. What I know to be true is when you center the rights and freedoms of the most targeted and marginalized people, you end up defending the rights and freedom of all people. Black people have shown us this, disabled people have shown us this, and our trans and queer people throughout space and time have shown us this. Our Safe Hotlines report came into existence through a deep awareness that trans and queer folks, Black and brown folks, folks living with disabilities, and folks experiencing poverty, and all people living within those intersections and beyond deserve better. We deserve safety to unravel and to be held without fear of being pathologized, locked up, harmed, and abused. We deserve to ask for help without experiencing state-sanctioned violence. We deserve to reach out for support and have the person on the other side of the line live in a body that can relate to us, who doesn't listen just for the sake of risk assessment, but listens because they too understand what it means to try and survive this world. This means to try. This report is a collective offering to give people the tools to humanize each other again, to understand more deeply the ways oppression informs policy, and to build new worlds where carceral and coercive control are not at the root system of how we show up for each other. And we truly would not be here today without the incredibly deep work of the team who has held this report together. So I have the honor of introducing two people who deserve all the flowers in the world for their contributions and leadership in bringing this report to life. I would love to introduce you all to Olka Forster and Nemu HJ. Olka and Nemu, thank you so much for your dedication to this work, and I'll pass the mic to you now. Thank you all so much.
Thank you. Thank you so much, Kai, and thank you so much, Myles. My name is Nemu. I use they, them pronouns. And a visual description is I'm a Korean person with brown skin. I have orange, shaggy hair, eyebrow, and nose piercings. And today I'm wearing a red striped sweater. This report and research that has led to it has been a huge labor of love for the past 2.5 years. And I'm so grateful for everyone that was involved and all of you for being here today. My hope is that this report and this presentation will help give the information that our community needs in order to know how to access crisis hotline resources in their own definition of safety, as well as provide recommendations to bring hotlines such as 988 closer to what safety means for our community. I just want to provide a brief content warning that today we're going to be discussing topics of suicide and suicidal ideation, police violence, transphobia, forced psychiatric intervention, and death. So I invite you to check in with yourself now and throughout this presentation and take care of yourself as you need. So today we're going to begin this presentation in a moment with an introduction to myself and my fellow presenter, Olka. I will share a bit about Trans Lifeline and the Safe Hotlines campaign, as well as share a bit about the original study that we did to hear directly from help seekers to inform our key findings and recommendations. We'll then share a bit about why we're focusing on 988 and what the problems we see are. Mainly, that's broken down into issues of consent, safety, and transparency. And then we'll wrap up the presentation today with a summary of recommendations to improve 988. So a little bit about me. I'm the Education and Communications Manager for Trans Lifeline's Safe Hotlines campaign. And I entered this work as a hotline caller myself, a peer supporter, a survivor of crisis, and as someone who has supported some loved ones through involuntary psychiatric hospitalizations and beyond that. And I'm so excited to pass this off now to my amazing colleague, Olka, where they can share more about themselves.
Hi, everyone. My name is Olka. I use they and she pronouns. I'm the campaign strategy and program manager for Trans Lifeline Safe Hotlines campaign. And I became involved in this work to transform crisis care after having to be an advocate for my family member who has been detained by police, dehumanized, and involuntarily committed while experiencing mental health crisis several times. For over a decade, my work has focused on police violence, environmental justice, food justice, queer rights, and human rights. Thank you so much for being here today. For those of you who don't know, Trans Lifeline is a grassroots hotline and advocacy nonprofit. We offer direct support to trans people in crisis. We are for the trans community, by the trans community, and our mission is to connect trans people to the community support and resources that we need to survive and thrive. The Safe Hotlines campaign was launched in the spring of 2022 to bring our vision of a world where trans people and all marginalized people have the connection, economic security, care that we really need and deserve, free of prisons and police. The focus of the Safe Hotlines campaign is to educate on the need for community-based crisis care and resources, educate on current hotline practices and policies, advocate for the end of surveillance tools and non-consensual police intervention on crisis hotlines, and inform providers and policymakers of the trans-specific impacts of crisis services. We hope to continue to build power to increase all of our community-based alternatives. For this report, our amazing research team surveyed 210 people and interviewed 26 people who identified as having had either a difficult mental health situation, significant distress, experiences with suicidal ideation, or crisis in the last 5 years. We asked these participants about their experiences with crisis resources, their views, their experiences with crisis hotlines, and the impact of emergency interventions that were initiated as a result of contact with a crisis hotline. So, what is 988? And why are we focused on it? For those of you who don't already know, 988 is the largest hotline network in the United States. The Suicide and Crisis Line currently has over 200 crisis centers participating in their network, including formerly independent hotlines like the Trevor Project and the Veterans Crisis Line. 988 was officially rolled out in 2022 following the National Suicide Hotline Designation Act that transitioned the former 10-digit number to the new 3-digit dialing code, which is 988. These crisis centers provide 24/7 crisis response and resources. And in the 2 years that 988 has existed, they've received over 10 million calls, texts, and chats. To date, over $1.5 billion in federal funding has gone into 988. And that is huge. We are focused on 988 for these very reasons. It's highly accessible. If you have a phone, if you have a computer, you can call or text or chat 988. It's well funded, it's available 24/7, and really it represents this massive opportunity for crisis hotlines to improve their services and help more people than ever. The other thing about 988 is that it was created with the intention to divert mental health calls away from 911 and law enforcement. And specifically in the text of the bill that made 988 possible, 988 is tasked with serving underserved populations. These are folks who are at growing or higher risk of suicide, and that includes LGBTQ youth, minorities, and Indigenous people. The other thing about 988 is they're engaged in a nationwide awareness campaign. If you haven't seen yet, maybe you'll see at your bus stop or on a billboard or like somewhere down the street, there are 988 ads everywhere. And so this means that the US public generally is becoming more aware of their service. While 988 represents a significant expansion of crisis care, it also represents an expansion of non-consensual practices in social support services. 988 policymakers have adopted and defended the practice of non-consensual intervention, and doing so disregards the voices of hotline users, psychiatric survivors, human rights organizations, and crisis care experts who condemn this practice. So despite its good intentions in its design, in reality, 988 has created another pipeline for people who are experiencing crisis to come into contact with harmful interventions. These interventions can traumatize and discourage people from reaching out for help, and that is the opposite of what we want. So today, we're going to be talking about the problems with 988. First up, consent. That is a big thing. Safety, even bigger. Transparency, and ultimately with all these issues, how it impacts trust for hotlines, for crisis care services generally, and for the ways we want people to reach out for help when they need it. 988 has a big problem with consent. So before we get into 988's issue with consent, let's first talk about the key elements of consent. And this is part of a definition that we've come up with here at the Safe Hotlines campaign. I'm sure it doesn't have every single thing, but these are some of the key things that you absolutely need to have consent. First, you need clear, complete, and transparent information. If you don't know what is going on or what could happen, you cannot consent to something. You need freedom from coercion that is inclusive of pressure and threats. And we'll talk about some of those examples in a little bit. You need a clear yes, and you need to understand that consent is something that can shift at any time. 988's problem with consent includes non-consensual interventions. A non-consensual intervention is the process through which an emergency response is initiated without a help seeker's knowledge or consent. These interventions can include both the initial response when a help seeker's location is tracked and emergency responders are sent out and they arrive, and any additional interventions that take place from there, such as incarceration or forced hospitalization. Non-consensual intervention can also include instances where a help seeker might be coerced, whether they're pressured or threatened or someone insists that they consent to an emergency response. That is also non-consensual. 988 hotlines specifically employ non-consensual interventions by initiating processes of sending emergency responders, often law enforcement, to the location of help seekers they perceive to be at risk of harming themselves or others. These interventions are often framed as something that is necessary for the safety of an individual or their community. That is not true for so many communities, and in reality, non-consensual interventions actually set the stage for really unsafe experiences. These experiences, again, can be traumatizing, life-altering, and sometimes even lethal. The consequences of these interventions can exacerbate crisis, and they can decrease trust in hotlines. Again, not what we want. Proponents of non-consensual interventions claim that these benefits outweigh the harms. Existing research offers little evidence to support that argument. In fact, non-consensual interventions are considered violations of human rights and the right to health by the UN, the WHO, and several other global human rights organizations. Now, we are talking about non-consensual interventions, but we want to make sure that we name that emergency interventions generally, even those that can start out consensually, can become non-consensual as dynamics of race, gender, perception of risk play out between emergency responders and the people who are experiencing crisis. The repercussions of these interventions, emergency interventions, can also mean long-lasting emotional, financial, and physical injuries. Again, these are conditions that we know prolong and exacerbate crisis and thoughts of suicide. In our study, our participants emphasized that a hotline's use of non-consensual intervention, and even just the possibility that they could have their location tracked, that police could come, that they could be psychiatrically hospitalized, even just the possibility of that posed this looming threat during hotline conversations that impacted people's ability to be honest and vulnerable. For the people who did experience an unwanted intervention, those interventions, the harms of that lasted so far beyond their crisis, their hotline conversation. Again, for many, just the possibility meant that they wouldn't even engage with the crisis hotline at all. Something we want to talk about that's really important is the role of suicide risk assessments, right? We named that these emergency interventions happen when they believe that you are at imminent risk. And so what is the way that imminent risk is being determined for people? These suicide risk assessments. The risk assessments are evaluations conducted to assess someone's likelihood of attempting suicide. For 988 hotlines, their operators are trained to assess for the possibility of suicide on every single call, text, and chat. 988 operators are required to ask all help seekers, everyone who calls, everybody who texts, everybody who chats, some version of the questions. Have you thought about suicide in the past few days, including today? And have you taken any action to harm yourself? If a person says yes to either of these questions, the 988 operator is required to conduct a further assessment to determine whether this person is at imminent risk of harm. Suicide risk assessments are inaccurate and ineffective. In fact, in a meta-analysis of 50 years of research on risk assessments, suicide risk assessments conducted by a trained health professional were shown to be no more accurate at predicting suicide than random guessing, or by someone with no training, or by flipping a coin. In our study, participants described how these risk assessment questions introduced the threat of emergency interventions within the conversation. Interviewees shared their strategies of avoiding these unwanted interventions, including lying on these questions and sometimes even just hanging up. Despite the fact that these risk assessments are ineffective and they set the stage for potentially harmful interventions, 988 does continue to use the practice. In response to critique and feedback about these risk assessments, 988 has changed the name of suicide risk assessments to safety assessments. They're the same thing. This interview participant said, "Are you in danger of hurting yourself or others today?" is generally the script I'm familiar with, or something of that sort. It's really frustrating because I struggle with chronic suicidality, but it's not dangerous. It's in order to prevent it from becoming dangerous that I call these hotlines. But it sucks that less trained people hear the word suicide and they become like activated to behave in a certain way. And it's just like, oh my God, this is my time to call you. Why do I have to take care of you now? This is a really great quote. I think something that it illustrates is the ways that hotline operators, through this requirement, through this policy that requires them to save somebody's life, right? That's the language. That upon hearing these words, going through and following these requirements, that then suddenly it becomes a heightened situation where now the interview participants or the help seekers are managing the operators' feelings and anxieties and this feeling of duty to save somebody's life. We asked participants why they wouldn't contact a hotline in the future. And for most people, 88%, they said that they did not want to interact with emergency responders, including police. 80% said they didn't want to be psychiatrically hospitalized. I think this is really interesting because I see that 34, almost 35% said that they didn't want to share their personal difficulties with a stranger, which of course would mean you wouldn't contact a hotline. But I think it's interesting that there's so many people who actually are willing, who want to talk about their problems or their issues or their crises. And what's going to stop them is this possibility of harm from these emergency interventions. This participant said, "I think not having non-consensual, what do they call it, rescue, I really think other organizations could learn from that, because it's like there's this threat that's behind the conversation that makes it really hard to be vulnerable. Help seekers want informed consent. The participants that we interviewed called for greater emphasis on informed consent throughout Hotline's conversations. Informed consent was framed by many callers as essential for building trust in hotlines and improving the quality of support provided by them. In the case of emergency interventions, informed consent requires explicit disclosure of the possibility of interventions at the start of all hotline interactions. That could be in hold music, that could be something the operator says to you. Fully informing help seekers of both potentially the positive and negative impacts of emergency interventions. Increasing transparency about the process used to determine that an individual is at imminent risk. And a commitment to utilizing emergency interventions with the full and ongoing consent of help seekers. It is okay to allow people to make decisions for themselves. It's okay to not hide the fact that you want to help them in a particular way. And it's okay to listen to them when they let you know whether something is going to actually be helpful or harmful to them. "988 has a huge problem with safety. Through these emergency interventions, 988 hotlines have made themselves a part of a distinct pipeline that brings help seekers who are experiencing psychological crisis into contact with police and other emergency responders. Emergency interventions, especially when they're non-consensual, pose an enormous threat to people in crisis, particularly Black and Brown people, LGBTQ+ people, disabled people, poor people, and those who are at the intersection of these and other marginalized identities. Again, some of the same people that 988 is tasked with serving. Encounters with emergency responders, especially police, too often escalate to violence, psychiatric hospitalization, incarceration, and even death. Within our research, participants who experienced emergency responses initiated by crisis hotlines detailed encounters of police violence, discrimination, involuntary hospitalization, forced medication, and both physical and sexual assaults. In the case of non-consensual interventions, participants highlighted how experiencing these interventions can compound distress by stripping a help seeker of their agency and consent in a vulnerable moment. And this is so important because so many people are already in crisis due to having experiences where they were stripped of their agency and their consent. This is not the way. This participant said, "I feel like a lot of crisis comes from feeling a lack of agency and a lack of autonomy. So knowing that there is your last piece of autonomy to latch onto, and it's always effing snatched away for some reason." In recent years, the role of law enforcement in mental health crisis response and the broader criminalization of people with psychiatric diagnoses generally has gained significant attention. This has been driven in large part by Black organizers and disability justice activists who are confronting police violence. So today, we all know policymakers, mental health professionals, organizations like the American Public Health Association all recognize that police are greater sources of trauma than effective support for people in crisis. Police violence disproportionately impacts people perceived to have a mental illness, people of color, and gender diverse people. Existing research also shows us that experiences of police brutality are associated with both short and long-term mental health consequences, even for the people who don't experience it. One study showed that just exposure to police killings of unarmed Black Americans was associated with more days of poor mental health among Black Americans in the general population, with the largest effect being 1 to 2 months after exposure. These are just some of the people whose lives have been taken unjustly by police in the midst of mental health crisis. Sonia Massey, Victoria Lee, Wynn Rosario, Maurice Donald Johnson, Nigel Cullins, and our dear, dear trans kin, may she rest in peace, Kayla Moore. These are just some of the names, in so many names, of people who were in crisis, who needed support, who called for themselves or had someone else call on their behalf, and they are no longer here with us. And that is something we have to take really seriously. The experiences of our study participants supported these patterns. Participants described interactions with police that ranged from unpleasant to violent, including experiences of threats of violence from law enforcement, homophobic and transphobic slurs, having weapons pointed at them, being sexually assaulted, and being intimidated into consenting to searches of their living space. Even when participants did not experience physical violence or harm from law enforcement, many described their interactions with police as coercive and threatening. For many interviewees of colors, just the threat of police violence shaped every aspect of their interaction. And I can speak to that as somebody who has interacted with many police officers while my loved one was in crisis. It is not actually the people you want to be interacting with in that moment. Help seekers want cops out of crisis care. One of the most consistent themes in our interviews was the opposition to police-based responses to mental health crisis. The vast majority of interviewees expressed wanting hotlines to sever their relationships with law enforcement and wanting to remove police from mental health crisis response more broadly. Many interviewees also highlighted the specific threat the police pose to communities of color, LGBTQ+ people, disabled people, especially during an experience of crisis. This interview participant said, "I don't think the police should be having anything to do with mental health crisis or emotional distress. I think that we need mental health workers who are not partnering with police, because you shouldn't be looking at losing your freedom because you're in an emotional crisis. There needs to be a separation of mental health and police. It's completely inappropriate to have police interacting with emotional distress." Another participant said, "A lot of people do not have any type of safety with the police. So they would never call the police or want the police to help them, because you can't trust what the police would do." One participant described how law enforcement used coercive language to push them into going into the hospital, saying that they could either go voluntarily or involuntarily be taken in by the police. Again, this is a non-consensual interaction. And this example is really worrying. It shows that emergency interventions can present help seekers with this false illusion of choice that's really more coercive than consensual. Notably, even participants who did not report any kind of negative interaction with the police, the vast majority of whom were white, said that they would prefer not to experience a police-based response at all. I'm going to now hand it back over to my colleague, Nemu, who will talk to us a little bit more about the impacts of forced hospitalization. Thank you.
Hi, everyone. It's Nemu again. Thank you so much, Olka, for that really informative presentation. I'm going to be talking about another non-consensual intervention that is very concerning, which is forced hospitalization. The terms involuntary or civil commitment and forced or involuntary hospitalization all describe a process through which people considered a danger to themselves or others are held in a hospital without their consent. Law enforcement officials, mental health professionals, And judges are the ones that most commonly hold the power to initiate an involuntary hospitalization. Involuntary commitment typically lasts 3 to 4 days, but can be extended into a longer term detention that can last weeks, months, or even years. It should go without saying, but confining someone against their will for days and even years is not healing, and it's not safety. It's incarceration. Another issue with forced hospitalization in the US is that variation across states in both the legal process and reporting practices makes it challenging to collect large-scale figures on forced hospitalization. But available data suggests that the number of inpatient civil commitments is in the hundreds of thousands annually. Forced hospitalization is not a rare occurrence. I can tell you that from my experience being in community with trans folks and BIPOC who are more subject to these types of violence. These are hundreds of thousands of people that lose their agency every year, who are taken from their loved ones and then transported to a facility that they don't have the choice to leave from. For many people who experience psychological or emotional crisis, the intertwinement of the mental health and the criminal legal system often means that the mainstream mental health system perpetuates violence, inequities, and oppression. Research on experiences of psychiatric hospitalization have found that harmful and abusive experiences in the hospital setting are alarmingly common. Several of the people that we interviewed described harmful and violent events that they experienced or that they witnessed while in the hospital. And these included forced sedation, being strip searched, racial or gender-based discrimination, and sexual advancements from other patients. One person we talked to mentioned that when they were hospitalized, they asked what would happen if they didn't agree to a certain procedure or treatment. And they were told that if they didn't agree, then they would be sedated, which shows essentially that there is no consent in the system. This type of coercion is reminiscent to the experience of the interviewee that Olka just mentioned, who was told by police to go to the hospital voluntarily or involuntarily. And in both these situations, what's actually happening is there is no choice. This shows a connection between the carceral and the psychiatric system. Among the folks that we surveyed and interviewed for this report, those who had experienced psychiatric hospitalization also highlighted the numerous financial consequences of their hospitalization, and many of which have been understudied in existing research. Several of the folks we interviewed spoke to the economic consequences of their hospitalization, including a loss of employment and unexpected ambulance and hospital bills. Participants expressed that these financial tolls continued to affect them long after their hospitalization. I want to highlight this quote from a person we spoke to that really sums up one of the failures of forced hospitalization. They said, "I was just begging with the police. I was like, listen, the reason why I'm struggling, it's not going to make it easier. If I'm hospitalized in an inpatient way, that means I'm going to miss my shift at work tomorrow. If I can't do my job, I can't pay rent, and then I'm going to be homeless again." Forced hospitalization treats crises as an individual issue that can simply be treated instead of it a rational response to one's life conditions. So for many people, crisis stems from not having the things that we need to live, such as financial security, food, housing, gender-affirming healthcare, or community. Not only does hospitalization not even address these issues, but it exacerbates them by removing people from their community taking away control and agency, potentially subjecting people to harmful experiences, and then billing thousands of dollars for it. One of the mainstream arguments that is advocating for forced hospitalization is that it saves lives. But even this isn't true. So while hospitalization may prevent suicide attempts, during the period of containment in a facility, a variety of studies have found a connection between hospitalization and increases in both short and long-term suicide risk. Several of the folks we interviewed described increased short and long-term mental health challenges after their experience of hospitalization. Some participants not only reported stronger feelings of suicidality after hospitalization, but also described changes in the nature of their thoughts of suicide. So for one person that we spoke to, experiencing hospitalization made them determined to use a more lethal method of suicide in the future. This participant said, "I never had a concrete plan until after that happened. Then I immediately had a concrete fail-proof plan because that was never going to happen again. If anyone ever tried to call anyone on me again, I had my fail-safe, and I was going to get out of there in a casket, or, they were going to arrest me quickly. It was never going to happen again, and that's true to this day. I still have that plan. I don't like that I have that, but I do." This person that we interviewed really pointed to the fundamental and uncompromisable need for autonomy in order to live in this world. In this person's case, they would rather die than experience hospitalization again. For some people, thinking about suicide can be a way to cope, to regain control and an agency amid experiences where there is none, where there's harm and oppression. Forcibly hospitalizing someone, taking away their choice and control, especially during a vulnerable moment, can actually be what's deadly, not someone's initial thought of suicide. So I also want to briefly get into some of the trans-specific risks of hospitalization. Forcibly hospitalized trans people report experiencing discrimination and a lack of access to gender-affirming care, medication, and resources. Furthermore, a history of involuntary psychiatric hospitalization can be used to deny trans people the ability to give informed consent for trans-affirming surgery or hormones in the future. Trans people are in a really vulnerable position in the United States. Like Kai mentioned, there are over 600 active anti-trans legislation this year. Transness itself is still rooted in its origin as a psychiatric disorder and other psychiatric diagnoses. So I'm going to get into some of the trans-specific risks of hospitalization. So forcibly hospitalized trans people report experiencing discrimination and a lack of access to gender-affirming care, medication, and resources. And a history of involuntary psychiatric hospitalization can actually be used to deny trans people the ability to give informed consent for trans-affirming surgery or hormones in the future. This comes from the fact that transness is still rooted in its origin as a psychiatric disorder, and that other psychiatric disorders or a history of hospitalization is allowed to be weaponized to deny a trans person the validity of being trans and is used to question their sanity. Sanism and transphobia are both harmful, oppressive characteristics of the psychiatric system. And a further risk of all of this is that denying trans-affirming healthcare to trans patients often leads to psychological harm, including thoughts of suicide. So I want to take us back to 988. So where's 988 in all of this? Today, 988 officials acknowledge the dangers that emergency interventions can pose to help seekers. 988 has updated trainings for their operators to include information about the possibility of traumatic interactions with emergency services. However, 988 has taken no further action to ensure that their initiation of emergency interventions are transparent, are consensual, and are as safe as possible. To date, all 988 centers are required to establish and maintain formal collaborative relationships with local law enforcement, with 911, public safety answering points, and with mobile crisis teams in their area. And I want to add here that not all mobile crisis teams are divested from police, and it's not always clear to the public. So systemically and practically, 988 is set up so that it can and does enact non-consensual interventions and in ways that are unclear to the larger public. And this is the change that we want to see, not just an acknowledgement. So this takes us into our last issue topic of this presentation, which is 988's problem with transparency. There are several issues around 988's problem with transparency, but I want to focus on their emergency intervention policy. So all 988 hotlines are contractually obligated to employ emergency interventions for help seekers who are labeled as imminent risk with or without their consent. 988's intervention policies do not include any requirement to disclose the possibility of emergency interventions to help seekers. 988's advertising does not provide any disclosure about the possibility of emergency interventions, that it can include law enforcement, and that these interventions can occur without someone's knowledge or consent. Nor does 988 disclose in its advertising that it formally works with 911 to track people's locations for emergency intervention. So here are some examples of 988's advertising, and y'all have probably seen them around. Now that you know what they look like, I'm sure you'll see them even more. So we see a billboard and we see a public sign. One says, "Don't wait, call 988." And the other says, "The Suicide and Crisis Lifeline is," in all caps, "free and confidential." In this next slide, we see another billboard and another sign promoting 988. One sign says, "Get free help at the first sign of mental distress." Another says, "When you're in crisis, call or text 988. Since its creation, the 988 Suicide and Crisis Lifeline has increased its reach to the US public through its national marketing campaign. And as you just saw in this campaign, 988 regularly advertises itself as private, as confidential, and as a free resource for people in crisis, offering a safe space to discuss one's struggles. However, we know that 988 shares help seekers information with 911 in order to issue emergency interventions, and that these interventions can cost thousands of dollars. So 988 is neither private nor confidential. And while the phone call might be free, the interventions that can take place from that phone call are not. In spite of efforts by advocates and survivors of emergency interventions, 988 officials have continued to obscure the policies and the practices that render their advertising misleading and dishonest. This lack of transparency has meant that the greater public is largely unaware of these potential consequences of calling 988. Olka came up with a great analogy for this. In commercials for medicines, for example, you'll hear about all of the potentially great and supportive functions of the medicine, but then you'll also hear at the end of the commercial a long list of side effects. Usually it's said very fast. And then if you go to your doctor or if you look up the medicine online, you'll again see a disclosure or hear a disclosure of the effects that could be harmful or undesirable from taking that medicine. This is the kind of minimum transparency that should be expected of 988. It could happen on the front page of their website, in their ads, or in the wait times while connecting to an operator. In this next slide, I'm going to show you what kind of disclosure we actually get. So here's a screenshot of 988's website where we can see some information that addresses the question around 988 and its use of police intervention. You'll notice in the upper left-hand corner in the red circle that it took 4 web pages to get here, starting from 988's homepage. If you try to find this web page after this presentation, good luck. This page actually reads and says that the 988 Lifeline, and we've circled it, recommends that counselors contact emergency services for assistance only in cases where risk of harm to self or others is imminent or in progress. The word recommend here isn't just misleading, it is false. As I mentioned, it is 988 policy to issue emergency interventions in these imminent risk situations. Recommend implies that it's advice that can be taken or disregarded, but 988 centers and its operators are contractually obligated to do this. You'll also see on this webpage in the next paragraph that less than 2% of 988 Lifeline calls involve emergency services. I'll get into this in a little bit in this presentation, but 988 has this figure everywhere. It's a common talking point that minimizes the frequency of emergency interventions as though it is a rare occurrence that happens to a general statistic, not to actual people. And available data suggests that this number is a significant underestimation. So in our study, the folks that we surveyed expressed frustrations and struggles when it came to hotlines being vague and not being transparent about emergency intervention and geolocation policies. The vast majority of our study participants expressed that hotlines should always be transparent about emergency use. So that was just over 70% of folks who responded that. 13% said that hotlines should be transparent about emergency response most of the time. 14% said sometimes, and only 1.9% said never. So that stat and like other data is available in our report. One of the interviewees that we spoke to mentioned their own concern around 988's misleading advertising. They said, "Another frustration I have is the way that hotlines represent themselves to the public in terms of advertising for 988, for example. It's very unclear if you look at most of the promotional materials for a lot of hotlines that they are entangled with a carceral system. It's not clear on most of the messaging on the websites that they call the cops. You have to search pretty deeply into their frequently asked questions or terms and conditions." And as we just saw from looking at their website, this is true. We had to go 4 links in to find some information, and that information wasn't even accurate. So Now let's talk a little bit about data. So while 988 publicly shares performance metrics that include the total number of calls, texts, and chats received and answered, which to this date is over 10 million, the only figure that they provide on emergency interventions is in that often repeated talking point, which is less than 2% of Lifeline calls involve emergency services. Nowhere on the 988 website or in any material that they make available to the public do they actually share that number of calls annually that result in emergency interventions. They don't share the reasons for triggering emergency interventions, and they are not transparent about the number of interventions initiated without a help seeker's knowledge, request, consent, or collaboration. And I really want to emphasize here that these are lives we're talking about. These numbers are important because we need to know how many people in our community, how many lives are actually being affected by interventions and non-consensual experiences. So then we can use this information to better understand what's happening at a systemic level and how we can hold 988 and other hotlines accountable for harm and push for change. So in an effort to fill in some of these gaps of information and to provide transparency for help seekers, the folks involved in our research team solicited 988 officials for data about emergency interventions. We used the Freedom of Information Act. We submitted FOIA requests and data request forms. Our team sent FOIA requests to the Substance Abuse and Mental Health Services Administration in July 2022 and in June of 2023. So that administration, SAMHSA, is a branch of the U.S. Department of Health and Human Services, and they have a contract with Vibrant, which is the nonprofit that oversees 988. We also sent FOIA requests to the Department of Health in both California and in Florida to ask about data regarding their government-funded 988 hotlines. And we sent data request forms to several national hotlines affiliated with 988, including the Trevor Project, the Veterans Crisis Line, and Vibrant. None of these hotlines provided the data that we were requesting, except for the Trevor Project shared some partial data. So shout out to the Trevor Project for doing that. Y'all can see the figures that they shared in our report. SAMHSA finally acknowledged our FOIA requests in July of this year, so 2 years after our first request was submitted. And in their reply, they provided only partial responses that didn't contain any information about emergency interventions data. The information they did share was data that we could already find through immense research on publicly available documents. To date, 988 and its administrators have refused transparency about the total number of emergency interventions that they initiate, the demographics of who they initiate these interventions on, how many of these interventions are non-consensual, and the outcomes of these interventions, such as police interaction or hospitalization. So to bring this back, all 988 crisis centers are contractually required by SAMHSA to participate in data collection. So this includes collecting data about, in their own words, crisis encounter outcomes and satisfaction of the help seeker and the crisis counselor. 988 centers are also required to have follow-up procedures when an emergency intervention has been initiated. So this includes confirming whether or not emergency services made contact with the help seeker. And in cases where a crisis center is unable to confirm that emergency services made contact, they're required to take additional steps that can include providing the help seeker's contact and address information to law enforcement or a mobile crisis team to perform wellness checks until the status of the help seeker can be confirmed. And I mention all of this because with these data collection and follow-up requirements, we can reasonably conclude that 988 officials do indeed possess information about the context and outcomes of the emergency interventions they're initiating, but they are not disclosing it. So according to 988, as I've mentioned, interventions occur in less than 2% of all calls, but available data, like I mentioned before, suggests this is a significant underestimation. So here's an example of this. A study released in 2022 by the NRI revealed emergency intervention figures are significantly higher than their 2% or less talking point. This study included information on the outcomes from 988 centers as well as non-988 centers in 31 states. So this study isn't perfect, but that's part of why we're urging 988 to be transparent and accountable with its own data. In the states that reported data about emergency interventions, an average of 3.6% of calls resulted in law enforcement being dispatched. That was looking at 21 states. 16.9% of calls resulted in mobile crisis units. That was looking at 25 states. And 1.9% of calls resulted in emergency medical services. And that was looking at 17 states. One state that reported the highest number of law enforcement interventions initiated by crisis hotlines reported this figure at 17.3%. So here's a visualization of the numbers that I just mentioned. As you can see, the outcomes are divided into different categories. So it's difficult to know what the total percentage of emergency interventions on hotlines is. But deductive reasoning tells us that it's way over 2%. The percentage of calls resulting in law enforcement is 3.6% alone. And that's already over 2%. And we don't even know how many of these were consensual or not. Now, it's not a 988 standard or requirement to do this, but some individual centers affiliated with 988 choose to publicly share their call data around emergency interventions. So shout out to New Mexico for being transparent. Again, the figures shown here are divided into different categories of emergency response, such as hospitalization, 911, and police. But if we add up two sections, counselor contacted police with caller's consent and counselor contacted police without caller consent, that categorization alone, we get over 3% here. I also want to point out that the non-consensually contacting police figure is higher than the consensual one. So again, deductive reasoning tells us, looking at this entire breakdown, that 988's less than 2% figure is inaccurate here, at least in New Mexico. So this chart now in this new slide is again from New Mexico, but I want to highlight an extra concern around safety here, particularly for help seekers who share thoughts of suicide. You'll notice that the figures in this chart are significantly higher than in the previous one. Help seekers with thoughts of suicide experience non-consensual interventions at even higher rates. This chart tells us that 4.5% of calls that mentioned thoughts of suicide led to non-consensual police contact, 4.5%. If we add that to the figure of calls that led to police contact consensually, we see that over 8% of calls around folks expressing thoughts of suicide leads to police contact. And as we've covered in this presentation, the fact that police are more violent towards Black people, trans people, people who are perceived as having a mental illness, this data is extremely concerning around the actual practices around help seeker safety and carceral responses to suicidality. 988 claims it's an alternative to 911, but these figures show the strong link between 988 and the carceral system. So lastly, I want to highlight the issue of transparency and consent around 988's data use practices. So 988 obscures the fact that they can share any and all help seeker data, including identifying information shared during a hotline interaction. And they do this in order to initiate location tracking processes for emergency interventions. 988 is not taking accountability for this. They minimize their role in both sharing user data and in initiating location tracking because they rely on the technicality that help seekers are not technically required to share personal identifying information to receive help. And the fact that 911 is the agency that has geolocation capability, not 988, even though their crisis centers initiate the process. The fact that the public is unable to access information related to this taxpayer-funded public service is very concerning. For help seekers, the transparency of this information is crucial for us to make informed decisions about if or when or how we use 988 or other hotline services. And transparent and trustworthy data is key to understanding what is working, what isn't working, and what can be improved. As 988 continues to expand towards its stated goal of being the central hub for triaging all crisis care in the United States, the need for full transparency and change has never been more urgent. All right, so this is our last section of the presentation to end on kind of a more transformative note, which is how can 988 improve? Many of the help seekers we spoke to highlighted some main themes around transformation that we need from hotlines in order to have safe and consensual experiences. So one of the primary recommendations is that hotlines must end unhelpful and harmful practices. And this looks like, for example, ending the use of non-consensual interventions and establishing consent-driven request-only transfer and emergency dispatch policies. This also looks like ending collaboration with law enforcement. This also looks like ending the use of coercive practices to initiate emergency interventions. So this means ending the use of pressure or threats to convince help seekers to agree to an emergency intervention. And lastly, this looks like ending mandatory risk and safety assessments and all assessments that can result in the initiation of non-consensual interventions. Help seekers also demand that hotlines incorporate and center practices of informed consent. This looks like fully informing help seekers about the process of emergency intervention, including the aspects of location tracking and the outcomes potentially from it, like hospitalization or medical bills or criminalization. This also looks like acquiring informed and ongoing consent from a help seeker before initiating any type of emergency intervention or sharing their identifying information. And this looks like implementing a system where help seekers can, with full knowledge, remember, one of the aspects of consent, with full knowledge, opt into geolocation and data collection, not have that be automatic. And this would at least easily allow help seekers to then opt out of the threat of emergency intervention. We also have a call for increased transparency. So hotlines must increase transparency about their policies, practices, and hotline intervention outcomes. This looks like publicly disclosing data on the annual number, not percentage, because these are lives here, of calls, chats, and texts that end with emergency interventions being initiated. We want to know how many of these interventions are occurring without consent or collaboration. And we want to know the outcome of these interventions. What is happening to our people? Transparency also looks like demonstrating total transparency about the use of emergency services, the potential for non-consensual intervention and geolocation, and specifically all marketing materials at the start and during hotline conversations, and in easily viewable, accessible language on websites, apps, chatbots, and hold recordings. Transparency also looks like immediately alerting help seekers anytime an emergency intervention has been initiated, and making explicit to help seekers which questions, if any, are mandatory in a conversation. Lastly, transparency looks like explicitly sharing practices and policies of data collection. This includes providing clarity about when and how help seeker data and call, text, or chat recordings and transcripts are being used, how they're being stored, and how they're being transmitted. This next recommendation is around operator training. So hotlines must create and implement robust operator training protocols that center the recommendations of hotline users, of suicide attempt survivors, and psychiatric survivors, especially those from marginalized groups. These training protocols must include a development of human connection skills that prioritize curiosity, cultural competency, empathy, and validating the experience of a help seeker without judgment. Operator training must teach hotline workers how to provide personalized and relevant support by following the lead of help seekers. And training must teach operators to manage their biases, their anxieties, fears, and discomforts during hotline interactions. The last recommendation theme that I want to highlight today is that suicide and crisis hotline administrators and its regulators must further increase accountability to taxpayers, to its private funders, and to help seekers by instituting clear policies that protect help seekers' information. This can include formal reviews of data use practices and accountability measures for improper storage or use of help seeker data. This looks like implementing corrective measures for crisis centers that violate help seeker privacy, and implementing annual reviews of transparency and consent practices. So I know a lot of the information that was covered today highlight the failures of 988 and the crisis response system more broadly. But these recommendations from help seekers provide a clear pathway to build a safer, more consensual crisis response. This presentation is coming to an end, but please stay on a few more minutes for some important gratitude and next steps. So I first want to thank all of you so much for being here today. And I want to express huge gratitude to everyone who helped make this report happen, from the folks who took the survey and allowed us to interview them, the folks who were on the research team, and my colleagues and friends in this work who supported this happening. I hope everyone here learned something today or felt seen in this presentation. What you saw in this presentation summed up a good amount of the report, but not everything. So I urge everyone here to read the report in full for a more comprehensive guide into our other concerns with 988, our other recommendations to improve 988, and more help seekers' experiences. You can scan the QR code on this slide with your camera, or you can go to translifeline.org/988-report, and the website will also be shared in the comments. I'd also like to urge everyone to sign our Crisis Caller Bill of Rights. This Bill of Rights is a manifesto to what crisis callers deserve, which is safety, agency, and transparency. So please sign on to show your support and add pressure to our call for safe hotline practices. You can sign on by scanning the QR code or by going to translifeline.org/BOR for Bill of Rights. And this link will be shared in the comments. And lastly, we would love to stay in touch with all of you. You can join our newsletter by going to translifeline.org/safe hotlines list. This link will be in the comments. We're on social media as TransLifeline and Safe Hotlines. And we tried to answer some questions today in the comments, but I know that we didn't get to everyone. So I invite you to please email us at advocacy@translifeline.org. I'd really love to hear from you. So thank you all so much for tuning into this event, and a preemptive thank you for reading the report. I'd also like to give a special thank you to my colleague Olka for being the most incredible teammate in this. Their presentation was amazing, and please give them a shout out in the comments if you share in my gratitude. I'm going to pass it over to Myles now to close this out.
Hi again, Myles here one more time, just to reiterate how Nemu landed the plane for us. We are incredibly grateful for all the folks who participated in this report, volunteers, co-conspirators, anybody who's reached out to figure out what it looks like for them to take their next steps in contributing to improving the crisis hotline ecosystem. Big thank you to Nemu and Olka for all your work on this. We really believe we are a part of a collaborative effort here to build a world where transgender and non-binary people don't just survive, but we're able to flourish. And so just to hit the call to action 2 more times, you can sign up for the Safe Hotlines newsletter on our website, and you will be given information about all of the events happening in 2025 around moving in a direction where the findings from this report become actionable. And the second part of that is to sign that caller Bill of Rights. You can do that on our website. You can find that in the links on this video. But if you're on translifeline.org, you're going to see the Safe Hotlines tab at the top, and you'll click that, and you'll be connected both to the sign up for the newsletter as well as the opportunity to sign the caller Bill of Rights. With that, we have come to a close here. Any questions, again, can be sent to Nemu and Olka at advocacy@translifeline.org, and we will look forward to hearing from you. Thank you for being here, and you'll see what we have for you next if you sign up for that newsletter. Have a great afternoon. Thank you.